Hi, my name is Ana Feijão. I'm a cardiac sonographer working in Angola, and I'm here to give you some tips to apply in your echocardiography exams. I apologize for my English, which is not the best, but I will try to speak slowly. After releasing some videos with the basic concepts of performing the transthoracic echo, I received feedback with questions related to the practical part. This is how this project came about, approaching the step-by-step of an echocardiographic study in order to answer the various questions that arouse. Now, I work in a cardiology department at a private medical center with a Mindray DC-7T device, and I'm ready to give you tips and guidelines to optimize your echocardiographic study and get excellent diagnosis from it. This is the third video in a series of videos where I explain step-by-step a normal echocardiographic study. In the previous videos, I talked about parasternal long and short axis views, and in this video, I will talk about the apical views. After finishing the interpretation of the parasternal window in its long and short axis, we move to the apical window. So we ask the patient to lie down a little more. That is, they are not in lateral decubitus, they are more inclined to lie down in order to open the lateral area of the thorax. We can look for the tip shock to be able to find the apical window. Because the edge shock is not always noticeable, we can place the probe at the level of the fifth left intercostal space, more or less at the level of the anterior axillary line, where we place the V5 electrode on the EKG, and from here I make small movements to discover the heart. Always with the index of the probe facing the left shoulder. It may be necessary to move down a space or move the probe further towards the back or towards the front. You will see that over time you will gain experience in achieving the best apical image. I think that of all the windows, in my opinion, it is the window that challenges me the most. I always start with apical four-chamber. We should see the four well-open cavities: the left ventricle, the left atrium, the right ventricle, and the right atrium. Between the left ventricle and the left atrium, we have the mitral valve, and between the right ventricle and the right atrium, we have the tricuspid valve. Alignment must be done by the left ventricle. It must be centered and as long as possible. If the left ventricle is cut badly, the apex will appear more rounded. Beware of bad cuts that shorten the left ventricle. When we shorten the left ventricle, the segments we see as apical are not the apical segments, okay? After aligning the heart well, we must change the commands in order to improve our image. Decrease the sector as much as possible and adjust the depth so that we can visualize the cardiac structures we want, but without having too much extracardiac information, as this extracardiac space around the heart is ultrasounds that get lost there when they could be used to better define the structures we really want to see. I'm not saying that we shouldn't use echo to assess extracardiac levels. We should always do a summary assessment before decreasing the depth, but concentrating the ultrasound to what we really want to study is important. By increasing the heart to a maximum, we raise the frame rate and do not waste ultrasound intensity in places that do not interest us. So we start by assessing the heart at a general level. The size of the cavities, the contractility of both ventricles, the interior of the four cavities, the mobility and morphology of the atrioventricular valves in their insertion plane. We can also assess the pericardium, but it's not the ideal window to do so, okay? As the peristernal gives us information about almost all the cardiac structures, the apical area helps clear up any doubts we may have had so far during the exam. Attention, it is not a good incidence to evaluate the systolic behavior of the position of the mitral leaflets. Do you remember talking about the importance of evaluating whether or not the mitral valve leaflets pass the valve plane? This verification must be done in views other than the apical four-chamber view. Therefore, a prolapse should never be evaluated by this incidence. That is, if there is a leaflet prolapse, I will be able to diagnose it based on this incidence, but I cannot diagnose prolapse based on this incidence. Okay? Next step, evaluate the left ventricle. And although we already have a perception of how the left ventricle is doing through the peristernal view, what is certain is that it is in this view that we see the cavity in its entirety. First of all, we must guide our image well. Center the left ventricle in the sector and open the cavity well. The left ventricle must be in its most longitudinal section. We must see all segments of both the septal wall and the lateral wall. The gains must be adjusted so that the cavity is anachorogenic, but we have the necessary definition of the ventricular endocardium. And the focus. Normally, I directed it to the mesoventricular level, but if there is a bad window at apical level, I move the focus there. And I waste time here. I evaluate the walls and the myocardium, the echogenicity, if there are variations that have nothing to do with the technical commands, if the myocardium is granulated, the thickness of the walls, the symmetry of the thickness of the walls. I evaluate inside of the cavity if there are trabeculae, if there are false tendons, masses, if the papillary muscle is well inserted and well visualized, or if there are any thrombus. For those who don't know, the false tendon is a linear structure, as we can see here, that runs through the left ventricle cavity. It is an anatomical structure without any physiological significance and can cause a murmur. In children, it is one of the biggest causes of systolic murmurs. Regarding trabeculae are invaginations of the myocardium into the cavity. It is normal for them to exist in the right ventricle, but not in left ventricle, as there is an embryogenic process that compacts these myocardial fingers and gives a smooth appearance to the left ventricular endocardium. But what is certain is that it is common to find trabeculations in the left ventricle, and it is necessary to mention them in a report. And, of course, diagnose whether there are criteria for non-compactation of the left ventricle or not. In these examples, I would like to make you aware of the importance of calmly and carefully evaluation the contractile function of the left ventricle, whether global or segmental. If we are in the presence of a ventricle with systolic dysfunction, we must always look for changes in myocardial echogenicity, asymmetric changes in segmental contractility, and possible thrombi. It is important to locate and dimension the thrombus, understand how it behaves, if it has mobility or if it is attached to the wall, the contour of the wall of the thrombus, if it has flow inside it, and to have a three-dimensional perception of the dimensions of the mass through other incidents. In this example, we can see an echogenic image at the level of the apical segments with defined contours without exaggerated mobility adherent to the ventricular wall. It is also very important to evaluate the contractility. If all the segments contract in the same way, if there is any dysenergic movement, as we can see in these examples on the right, where there is a symmetry of contraction between the walls. As you can see, the septum and lateral wall do not have contractility synchrony, this being an example of dysenergic movement of the septum in a patient with complete left bundle block. Made the subjective evaluation of systolic function, we step for the measurement of the ejection fraction. Ejection fraction is one of the most important parameters for assessing left ventricle systolic function. Despite being a very volume-dependent parameter, apart from global longitudinal strain, it is my favorite to quantify systolic function of left ventricle. To do this, start by acquiring a good image in order to obtain the best possible definition of the ventricular endocardium. If necessary, I can even decrease the depth and reduce the image sector in order to increase the frame rate and the definition of the two-dimensional image as we see in this example. If there are dropouts, there is areas where we lose ultrasound information, lacking continuity in the grayscale image, we must acquire another period as not to reduce the sensitivity of the calculation. So I freeze and choose a cardiac cycle. We must choose the best frame in left ventricle telediastole, okay? And define in the software, in the left ventricle menu, the Simpson measurement. And the caliper will appear. We must mark the caliper on the endocardium at the level of the mitral septal annulus and contour the endocardium of the entire ventricular cavity until reaching the lateral mitral annulus. In the measurement, we must include the trabeculae and the papillary muscle inside the cavity. When giving OK, the software automatically defines the mitral annulus as a straight line that joins the 2 points of the mitral annulus, and also automatically launches a longitudinal cursor that we must align with the major axis of the left ventricle, that is, with the length of the cavity. Once completed, I press to finalize, and it gives us the left ventricle and diastolic volume. After measuring in telediastole, I do the same procedure in telesystole. At the end, the software calculates the relationship between the systolic and the diastolic volume with the value of the ejection fraction. The software estimates a ventricular volume by approximating the ventricular cavity to a cone. Do not forget that in situations of alteration of segmental contractility, we must quantify the systolic function based on the biplane ejection fraction. That is, do this sequence that I explained in 4-chamber apical view and in 2-chamber apical view. And don't forget something very important. We must always calculate telediastole and telesystole in the same cardiac cycle. Mitral annulus plane systolic excursion and mitral annular systolic velocity are another left ventricle systolic parameters. Both of these measurements evaluate the apical movement of the mitral annulus, which in compromised ventricular function is not so exuberant. To calculate mitral annulus plane systolic excursion, I place the lateral wall centered on the screen, select the M-mode cursor, and evaluate the excursion from its diastole point to its systolic nadir in a vertical line, not diagonal. To measure the myocardial velocity of mitral annulus, I must call the PW cursor and place it on top of the lateral ring, and I will have a graph like this. This graph represents the myocardial ring velocities, having two diastolic curves and one systolic curve. In this systolic curve, we must measure the maximum velocity, and the greater the myocardial velocity, the greater the systolic dynamism of the left ventricle and therefore its systolic function. Another parameter I like to calculate, especially if the diastolic function is somewhat indeterminate with normally calculated parameters, is the propagation velocity. Propagation velocity is the velocity of mitral flow at the beginning of diastole, and it's closely related to tau, a diastolic measure calculated by invasive methods. To calculate the propagation velocity, we must place the color Doppler window over the mitral valve. I call the color Doppler window, lower the general bidimensional gains, and orient the sector size so that the left ventricle inflow track is in the middle, and be able to perceive the dynamics of the diastolic flow right at the entrance of the left ventricle. I reduce the color scale to 40 centimeters per second. Then I place the M-mode cursor aligned with the mitral flow, and record its behavior. The propagation velocity is calculated on this initial flow slope. Having assessed the left ventricle, I will assess the right ventricle in the fourth chamber view with the right ventricle centered. The right ventricle should appear in a triangular shape on the left side of the screen, in a normal heart, of course. The moderator band and the more apical annulus of the tricuspid valve identify this cavity. To study the right ventricle, we can center it on the screen so that it is more evident and we can see the free wall of the cavity well. I must orient the probe so that the apex of the right ventricle is in the center of the sector and the basal diameter is as large as possible, avoiding longitudinal shortening of the right ventricle, don't forget. To do this, I rotate the probe counterclockwise and make small tilts in order to center the longitudinal axis of the right ventricle. We must evaluate the systolic behavior of the free wall throughout its entire length. We must look deep into the cavity, and it is a perfect view to evaluate the moderator band. I assess the contractility and thickness of the free wall. I always check that there is no heterogeneity in the thickness and echogenicity of the free wall. Beware of arrhythmogenic right ventricular dysplasia that easily goes unnoticed. And I also evaluate the inside of the ventricular cavity. This view is ideal for taking the three measurements of the right ventricle: the basal measurement, the medium level measurement, and the longitudinal measurement. The basal dimension must be calculated in the maximum dimension at telediastole. This measurement is simple, quick, and easy to calculate, but the right ventricle measurement may be underestimated due to right ventricular cutting in this way. The dimension of the right ventricle at the mid-level should be carried out transversely in the middle third of the right cavity, approximately in the middle of its longitudinal axis, always in telediastole. Do not forget that we must indicate in the report the location of the measurement. Another important piece of information to take into account. In patients with pacemaker, it is important to evaluate the interaction of the lead with the tricuspid valve and within the cavity. And don't forget to mention the presence of the electrocatheter in your report. To quantify the right ventricle systolic function, I calculate the tricuspid annular plane systolic excursion, also called TAPS. I measure the tricuspid annular systolic velocity by tissue Doppler, and I calculate the shortening fraction based on the right ventricle area. To calculate the TAPS, I call the M-mode cursor and place it over the tricuspid annulus of the free wall. It must be aligned with the movement, as we can see in this example. Since the measurement is dependent on this alignment, don't forget to have this caution. I have this tracing in M mode and I calculate the linear distance that goes from the ring in telediastole to telesystole. Beware of oblique measurements. Area fractioning. To calculate the shortening fraction based on the right ventricle area, we must measure the right ventricle area. I outline the endocardial border of the right ventricle in telediastole and then in telesystole. Trabeculae, papillary muscles, and moderator band should be included in the cavity area. To calculate tricuspid systolic velocity, I place the PW cursor over the ring, tricuspid ring, also aligned with the movement of the ring. Don't forget that is angle dependent. The PW sample should be approximately 5 mm and the gains and filters should be changed to a lower level. I activate tissue Doppler by pressing the PW command again and evaluate the velocities of tricuspid annulus, very similar to the protocol used to evaluate the spectral graph of the velocities of the mitral annulus. The tricuspid annular systolic wave is a measurement that helps in the assessment of right ventricle systolic function, but in cases of thoracotomy, pulmonary thromboendarterectomy, or heart transplantation, it should not be taken into account. Continuing with the exam, the next step is to evaluate the left atrium. I orient the probe in such a way as to open the left atrium well. Be careful, the orientation of the probe to evaluate the ventricles may not be the same to evaluate the atrium. That is, we may need to apply some taps or tilts to center and open the cavity we want to assess. So I put the focus at the level of the left atrium, and if you think it's necessary, you can zoom it. I usually don't. Before freezing the image, freezing is stopping the image, to calculate the volume and or area, because it's the same, I observe the inside of the cavity, the walls, and I see if there is any echogenic image or different structure, such as a false membrane. Before taking the measurements, I carefully evaluate the limits of the moving cavity so as not to include the pulmonary veins in the atrium measurement. Then, we can do 4 measurements. 2 linear measurements, one transversal and the other longitudinal, the area measurement and the volume measurement. It is important to know that area and volume are calculated in the same way and are more sensitive to the real size of the left atrium, taking into account that its measurement includes several linear measurements automatically calculated by the device. So first, longitudinal measurement should be performed from the mitral valve plane in a line parallel to the interatrial septum up to the roof of the left atrium. And the transverse measurement should be measured from the middle portion of the interatrial septum in a parallel line to the mitral annulus to the lateral wall of the left atrium. Not difficult, you can see in the image. Both the area and volume of the atrium must be calculated in telesystole, in the frame just before opening the mitral valve, which means measuring when the atrium is fullest. Okay? And how do we measure these values? Mapping the endocardium of the atrium wall, excluding the area below the mitral annulus, or you see, between the leaflets and the annulus, and the entry chamber of the pulmonary veins. Don't forget to evaluate the index volume, that is the volume calculated by mapping divided by the patient's body surface. So, and this protocol is the same for measurements of the right atrium, okay? Don't forget it. Pulmonary vein flow is a flow that requires some expertise from the echographer, making it a second-line quantification parameter, at least for me. But it's a flow that helps in quantifying diastolic function. Normally, this view, we can see 3 pulmonary veins. The depth must be adjusted so that we can see the vein opening in the left atrium. Normally, we see the right pulmonary vein, here the upper one. So we put the collar sector, we placed over the mouth of the vein, as small as possible to keep frame rate high, and the collar scale smaller than 40 centimeters per second. You can see here we have the opening of the right superior pulmonary vein. We place the sample in the entry port and align the cursor with the flow. By pressing the PW command again, we call the spectral graph, and it's something like this one. It may be necessary to down the filters, and it's important to pay attention not to catch the speed of wall of the atrium, okay? The sample must be in the pulmonary vein, not in the atrium wall. And we must have these 3 waves: the S wave, the systolic wave, the D wave, the first diastolic wave corresponding to the rapid filling phase, and the A wave, the second diastolic wave corresponding to the phase of the atrium contraction, thus justifying the negative wave, that is, when the atrium contracts, it will push blood back to the pulmonary vein. If there are doubts regarding the wave detected in the spectral graph, you can always correlate it with the electrocardiogram to understand the phase of the cardiac cycle and thus the recorded wave. Systole begins at the beginning of the QRS and ends at the end of the T wave. Diastole goes from the end of the T wave to the beginning of the QRS. Not forgetting that the atrium contraction phase corresponds shortly after the end of the P wave. Next, I evaluate the mitral valve. I place the focus at the level of the mitral plane and see how the leaflets open. If there is any mass or attached structure or any calcification. In these examples, we can see a normal valve, with preserved opening and only slight thickening. But in the example on the right, we already see a very calcified valve. This hyperechogenicity in the ring and leaflets is a sign of calcification, without the characteristic definition of the leaflets. After evaluating the mitral valve by two-dimensional, I evaluate it with color Doppler. I call the color Doppler window, lower the general 2D gains, and orient the size of the sector so that the mitral valve is in the middle and be able to perceive the dynamics of the diastolic flow and regurgitation. It is rare that there is no regurgitation, even if it is a very tiny central jet, as in this example, in this first one. In the second example, we can perceive that the mitral regurgitation is greater than in the left example and extends along the left atrium wall. This is called Coanda effect and represents this flow movement along the wall. If there is a significant regurgitation, I can calculate the PISA and the regurgitant volume, here using the PISA method, but these are theories for another video. Once the mitral valve is evaluated, I will evaluate the mitral diastolic flow. First, I keep the color Doppler window. To evaluate a specific zone, I call the Doppler, the PW cursor, and I set the sample to 1 to 3 millimeters and place it 1 millimeter from the tip of the open mitral valve leaflets, a little closer to the sidewall, bearing in mind that the flow is ejected in that direction. I press PW again in the commands to call up the velocity graph, and I will have a graph that looks like this. As I have already mentioned, whenever we activate the spectral graph, it is important to orient the baseline and the velocity scale so that we can visualize the peak of the curve to be studied. And we must also orient the gains and filters so that the entire spectral curve is well defined. Then I measure E wave velocity and A wave velocity, and also E wave deceleration time, useful parameters for assessing diastolic function. By measuring the deceleration time of the E wave, I will also have the mitral valve area information by ME pressure time. Taking into account that several factors interfere with transmitral flow, it is important to talk about some situations that may arise even in a normal exam. Although the transmitral flow has a normal presentation with an E wave taller than the A wave, in elderly patients it is normal to find a flow with altered relaxation. There is E wave being smaller than the A wave. In these cases, it is important to correlate it with other diastolic parameters to confirm whether it is a degenerative change in the heart or whether we are experiencing a case of mild diastolic dysfunction. In the case of a patient with sinus tachycardia or with some type of atrioventricular block, there may be fusion of the A wave in the deceleration ramp of the E wave. In these patients, deceleration time should not be measured. We can also, as a protocol, ask the patient to perform a Valsalva maneuver, a deep inspiration or push the belly, to understand the behavior of the mitral flow with Valsalva. It gives us important data about the diastolic function. Do not forget that the mitral flow must be evaluated 10 to 12 seconds after the maneuver. For us to know that the maneuver was well performed, the E wave velocity must be less than 20 centimeters per second or decrease by 10% or more from its baseline value. In normal patients, there is a relatively identical decrease in the E wave and in the A wave. But in patients with high left atrium pressure or moderate diastolic dysfunction, the E wave velocity decreases so much that there is a decrease in the E wave and A wave ratio. We can see this situation in this example, where before performing the Valsalva maneuver, the EA ratio is greater than 1, but after deep inspiration, the ratio reduces significantly, suggesting increased filling pressure. Don't forget one thing, the duration of the A wave is an important parameter in the assessment of diastolic function, often leading to a tiebreaker of opinions. But contrary to what many think, it should be evaluated with the PW cursor sample at the level of the mitral annulus and not in front of the leaflets, where we place a sample to evaluate transmitral flow. Next, also at the level of the mitral valve, I will calculate the mitral annulus velocities, another very important parameter for assessing diastolic function, and also for assessing the systolic tissue velocity that I said on a slide back in the presentation. So I keep the PW Doppler active, but this time I place the sample first at the level of the lateral annulus, at the junction of the lateral left ventricle wall and the mitral annulus. And after measuring the maximum wave speed E and A, I place the sample at the level of the septal or medial annulus at the junction of the septal left ventricle wall and mitral annulus. The PW sample should be approximately 5 millimeters and the gains and filters should be changed to a lower level. I turn on tissue Doppler, it is normally referred to in the software as TDI, and assess mitral annulus velocities. First from lateral and then from the septal. Here is an example of a lateral tissue Doppler measurement, and here we have the negative E and A wave, taking into account that these are diastolic waves during relaxation. The mitral annulus moves away from the probe, so they are negative waves. And the positive wave, S, which represents myocardial movement in systole of the mitral annulus approaching the apical segments, and thus the probe being a positive wave. The septal E and lateral E are extremely important for the quantification of the diastolic function, and S is a systolic parameter like I told earlier. If by chance your ultrasound machine is old and does not have the tissue Doppler control, what I recommend is trying to do it with PW Doppler. Place the sample, as I explained, at the mitral annulus, lateral or septal, and call the spectral graph. The big trick here is to lower the speed and manage the gains so that we can achieve a good definition of the tissue wave that will have a more intense echogenicity. It is not ideal, but I confess that I've worked on an ultrasound machine without TDI, and E is a very important parameter for evaluating diastolic function. So it doesn't hurt to see if we can get a good definition, or if using Doppler PW to provide more information to add to the report and diagnosis, okay? The next step is to evaluate the tricuspid valve structurally and its function. I see the behavior of the leaflets, the insertion to be compared with the mitral valve, and it must be inserted in a plane above. And I call the color Doppler window to see how the flow behaves. Calling the Doppler window, I lower the overall 2D gains and I orient the sector size so that the tricuspid valve is in the middle. you should be able to see diastolic flow and regurgitant flow. In these two examples, we can see an example of a slight mild regurgitation appearing coded in blue, taking into account that it is a flow that moves away from the lobe, right ventricle to right atrium flow. And in this example here, we have an important regurgitation with a larger blue area occupying a large area of the right atrium. Next, I usually calculate the right ventricle, right atrium gradient, again to calculate the maximum velocity of tricuspid regurgitation that allows me to quantify the systolic pressure of the pulmonary artery. Taking into account that tricuspid diastolic flow does not have great clinical significance, if I have already evaluated it in the peristernal short axis at level of the basal vessels, I no longer evaluated it in this view. It is important to evaluate maximum velocity of the regurgitant flow in order to calculate the systolic pressure in the pulmonary artery. As it is to evaluate the velocity of a regurgitant flow, there is with high velocities, I use CW Doppler. I place the cursor in line with the regurgitant flow and press CW command again to call up the velocity graph. Do not forget to orient the baseline and the velocity scale so that we can visualize the peak of the curve to be studied. And we must also orient the gains and filters so that the entire spectral curve is well defined. Then we observe this type of graph with a negative rounded wave, which can be well defined as in this example, or blurred as in this one. Attention, we should only proceed with the calculation of pulmonary artery systolic pressure if the maximum regurgitation velocity is well defined. In these two examples given, in this one, we can see a very well delineated definition of the Doppler curve, while in this example, we do not have a clear perception of the maximum peak. So, in the second situation, we must find incidents that allow better alignment with the flow in order to have a better defined contour. Or concludes in the report that it was not possible to calculate the systolic pressure in the pulmonary artery due to poor definition of the CW Doppler flow. The septums. We should also observe the behavior of the septa, interauricular septum and interventricular septum, during respiration to understand ventricular interdependence and changes in the intracardiac pressure. It is not ideal orientation, taking into account that the structures are parallel to the ultrasound beams and it can give artifacts in the image and in the color Doppler, but it is more information that we have for our report. The septum must be evaluated in 2D, and if in doubt, small tilts must be made in order to achieve some transversality between the structure and the ultrasound beam. We must call the color Doppler, make the sector window as small as possible to improve the frame rate, reduce the overall gains, and set the color scale to a speed that does not cause aliasing, like 50-60 centimeters per second. And with the color sector above the area, we stud and I tap the probe a little bit to see if any strange flow appears in an extra plane. Be careful with the flow of the inferior vena cava. Sometimes it is an exuberant flow that impinges on the interauricular septum and can cause turbulence on the right atrial side of the septum, mimicking a foramen oval patent or even interauricular communication. If you have any doubt, freeze the image and move the mouse around in order to make a temporal evaluation calmly and frame by frame. The coronary sinus is a structure that empties into the right atrium and brings venous blood from the coronary circulation back to the heart. This structure can be well visualized in some patients through this route and appears in a tubular shape on mitral valve. We can also visualize a filamentous structure at the mouth of the sinus that corresponds to the valve of Thebesius, not seen in this example. Okay? The 5-chamber apical is a 4-chamber apical but with the appearance of the aorta. To reach this route, I tilt the probe slightly anteriorly until the aorta appears above the interauricular septum. In this way, I evaluate the mobility of the aortic cusps, and by placing collar over the valve, I can perceive the behavior of the systolic and diastolic flow. It is also an incidence where we must morphologically evaluate the left ventricular outflow tract and the supravalvular region. We then assess the dynamics of blood flow with color Doppler. I call the color Doppler window, lower the general 2D gains, and orient the sector size so as to place the aortic valve in the middle and be able to understand the dynamics of systolic flow and regurgitation if existent. In this example, we can see systolic flow with a lot of turbulence. This may be due to some obstruction of the left ventricle or some pathology of aortic valve, or also an increased cardiac output. This view is also good for understanding the behavior of aortic regurgitation and how far it reaches the level of the ventricular cavity. As we can see here in B, it's a small one. Then I keep the cursor aligned with the aortic valve and call the CW Doppler because the aortic velocities are higher and sometimes the PW does a liaising, okay? When pressing for the second time on CW command, it calls the spectral Doppler and gives us a negative systolic flow because it's a flow that moves away from the probe with this triangular aspect. As I have already mentioned, whenever we activate the spectral graph, it is important to orient the baseline and velocity scale so that we can visualize the peak of the curve to be studied. And we must also orient the gains and filters so that the entire spectral curve is well defined. Therefore, to obtain the spectral graph of the anterograde velocity of the valve, I place the baseline higher because it is a negative flow. We must choose the VTI aorta option in the measure menu and we contour the spectral graph to obtain two very important values for evaluating the behavior of the aortic valve, the maximum gradient and the mean gradient. If we diagnose aortic regurgitation by color Doppler, we must align the CW cursor over the regurgitant flow and we get a graph that looks like this. However, to evaluate the second graph that represents the speed of aortic regurgitation, I have to move the baseline further down. Normally, we have to increase the speed scale so that the peak of diastolic flow is clearly visible, and I then obtain a positive curve with a deceleration ramp that is slower the less severe the regurgitation. I must calculate the deceleration ramp, which allows me to quantify the regurgitation. Then I evaluate the left ventricular outflow tract flow. I activate color Doppler and I place it in the zone I want to study, left ventricular outflow tract. I set the focus to this level and adjust the color sectors so that only the flow I want to evaluate is left. We should also lower overall 2D gains. How to evaluate a specific zone? I call Doppler PW cursor. I set the sample to 4 millimeters or less and place it where I want to evaluate, before the aortic valve, the aortic cusps. Then I call up the spectral graph by pressing the PW command again. And I get a flow that looks like this. Do not forget that we must orient the baseline and the velocity scale in order to visualize the peak of the curve. So I contour the systolic flow and the software automatically gives me the left ventricle VTI. Another important measurement in this view is isovolumetric relaxation time. This parameter is calculated on a spectral plot that captures the left ventricle outflow track and the transmitral flow. And how do I get this graph? I keep the color Doppler window over the aortic valve, widening the sector a little more in order to capture the mitral valve flow. To evaluate a specific zone, I call the Doppler PW sector. I set the sample to 1.5 to 2 millimeters and place it in the middle of the two streams, here. I press PW again to call up the velocity graph. And I will have a graph that looks like this, which catches the flow from the left ventricular outflow track here, negative, triangular shape, and catches the transmitral flow with two waves. I orient the baseline and the velocity scale according to the needs so that we can visualize the curve well. And isovolumetric relaxation time is calculated here, starting where left ventricular flow ends and ending where mitral diastolic flow begins. So we evaluated the apical 4-chamber view and 5-chamber view. It remains to access the 2-chamber and 3-chamber views. Let's go. So the remaining apical views are important for us to understand the segmental function of the other walls and to understand how regurgitation behaves in 3 dimensions, or the dimensions of a mass, the mobility of a visualized structure, etc. I usually do a sweep, or I start again at 4-chamber apical view. I can see the contractility of the septum inferior and the lateral anterior wall. Then I angle the probe anteriorly again to a 5-chamber apical. I assess the interventricular septum anterior and the lateral anterior wall. Then, for a 2-chamber view, I rotate the probe, mark approximately 60 degrees counterclockwise. In this view, I will only have left ventricle and left atrium. So I evaluate the inferior wall and the anterior wall. To obtain the 3-chamber view, which turns out to be a peristernal long axis view with the visualization of left ventricle in its entire longitudinal dimension, I continue to rotate the probe counterclockwise until the aorta appears, visualizing here the lateral inferior wall, formerly called the posterior wall, and anterior interventricular septum. Like I told you, apical view, it's not an ideal window to evaluate pericardial effusion, but in large effusions, it is an incidence that allows us to assess, above all, the cardiac functional response. As for example, the respiratory variation of the flow, as we see in this example, the paradoxical movement of the interventricular septum, that is characteristic of pressure overload of the right cavities, and if present, the collapse of the right cavities. I hope you enjoyed. If you have any questions, please post them in the comments or email me. Bye. And here I finished the video on the apical view. In the next video we will cover the subcostal window and suprasternal window.